33-year-old male smoker, acute chest pain for 4 hours at the MIS. So what do you guys think? Sounds like just the bread and butter acute coronary syndrome, maybe?
Yeah, 33.
So what do you think it is? Mo? What do you think it is? PE? You think echo is useful in this guy? Okay, you think echo is useful. Okay, that's good. Vasospasm? Okay. Yeah, it could be. It could be a coronary event. It could be. So, what's that? It could be dissection. So the bottom line, what do you want to do, Mohammed? If you were just treat him as ACS, do something before.
Chest X-ray.
Sure, chest X-ray showed. Chest X-ray showed a little bit wide mediastinum. Let's see. So who wants to? Who wants? So okay, is it a PE? Yes or no?
No.
No. And I don't need CT for that. I'm done. Somebody with troponin of 10 and that RV does not have PE. You don't have to do a CT for that. Okay. Let's say there are two of inversions in anterior precordial lead, so it's LAD territory. Is it an LAD ischemia? Apex is moving, very good, eh? Very well. So, what is it? Anything else on this echo that's clear? Not much, eh? It's a good echo. Nothing. Okay, that's good. Let's keep going. So the short axis, parasternal short axis window. Anything you don't like Rex didn't like something? Yeah, I would also question that. Now that we talked about that last time. Parasternal short axis views are terrible for wall motion because of foreshortening. You always foreshorten when you do it. It's not a circle, a donut. And it gives you an impression that there is wall motion abnormality. So I will be very careful talking about wall motion abnormalities in a short axis.
Also, because you have the abdomen, so you have all the fibrous portion in the interceptor.
Right. That makes it looks like hypokinetic here, right? Okay, Mo. Now, that's a parasternal long axis.
It's definitely a PE. It's definitely a PE.
The most striking thing is the dilated aortic root.
Right, dilated aortic root, like severely dilated, little bit dilated. Yeah. What else? Yeah, agree, 100%. That's a striking abnormality. What else is there? LV? You can see it.
Actually, yes.
Right. You see that thing that's dancing?
Yeah.
That's the flap. Absolutely. There's an intimal flap. Now, in type A dissections, that's usually where you're going to see the flap. It's usually 65% of cases of type A dissection. It's about 2 to 3 centimeters from the coronary buttons. That's exactly where you see it. So I don't understand anybody who says transthoracic echo is not useful for type A dissection. I don't understand it myself. I've seen so many presentations that we caught type A dissection instead of treating ACS because we did an echo. Problem a lot of non-STEM is we don't do an echo sometimes. We're busy. We say, okay, heparin, cath tomorrow.
This is quite decisive in this case. I mean, certainly there are cases that will have a flap that won't be as obvious in terms of the root dilatation.
Right, and then you can just do a CT if you suspect, but you're not sure, right?
You usually don't see a flap, you see a big dilated root.
Right.
In somebody like this.
Right.
You have to think about it.
Oh, when you see that, it's a dissection. So when you do CT after this, it's not because you want to confirm the diagnosis. It's because you want to see where does it extend to.
Yes.
That's all. You want to see because the surgeon wants to know where does it go to the end, right? So, Mo, want to continue? Color?
Yeah, I was going to choose AI with it.
How bad is the AI?
It's quite a bit of rejects.
Is it turbulent or laminar? So, red then blue, no yellow, no turbulence. So this is a laminar. Laminar in regurgitation means wide open, severe. There's no question. When you see that for mitral valve, tricuspid valve, laminar flow, this is severe. Okay. So the laminar flow, severe AI. So it complicates things. Okay. So the valve is involved. So this is the CT. That's the ascending there. Look at the ascending, how big it is.
Wow.
Right. Look at the flap. Oh, sorry, it's too bright. Maybe the flap wasn't clear. There is a huge flap. See the flap?
Yeah, you can see it.
Huge aorta, is like very big. Okay, so what segments of the aorta are feasible to see with transthoracic echo, and what window? Anybody wants to take a shot on that? Or I can just... Okay, so here we have a model. Okay, so this area, which is the aortic root and the beginning of the ascending, is usually easy to see. So I would say that this can be seen easily with a parasternal long axis window, right? Sometimes you can't, but most of the time you can. This area is totally missed on transthoracic echo. The tubular ascending aorta. Now you can sometimes move one rib above to see that area, but not always work. It doesn't always work. Now this area, which is the aortic arch, you can probably see it with a suprasternal window, but not always that window is good. In intubated people, it's never good. Descending, you can probably see it with a subcostal window, but you're not going to see the thoracic descending. You're going to see the abdominal descending. So you're gonna miss a good chunk of this. So we're going to end up seeing this. Oops. Maybe this and this.
Actually, rarer to get just a type A without having the descending portion affected.
Correct.
So one of the things with the TTT that people recommend is to go quickly because vision is stable. Is go straight with descending. See if you see something that's really quite easy to see. If you see something there, like doesn't like the vision's not stable, like you know that it's going to be descending,
right,
even if you can't see the root well.
Right.
So it's one of the things to think about in the order of things you're going to look at.
Yeah, most type A's extend to, like, includes the descending aorta. Having said that, there are a lot of acute aortopathies, like a hematoma or ulceration in the aorta, rather than that, not necessarily going to involve the descending aorta. But the bottom line is, we're going to talk about this here in a sec. So what segments of the aorta are feasible? Aortic root, aortic arch, and abdominal descending. I would say this no, this no. Okay, so there are other transthoracic echo findings other than visualizing the flap or the double lumen that can be helpful. And we talked about some of them: AI, pericardial effusion, and dilated aortic root. Those can help you to know that it's a dissection, probably, right? If you see an effusion and it's tamponading, and with the presentation's chest pain, think 3 times before you put a needle. This is probably a dissection, so you can cause trouble. So those are some images. This is the aortic root here and the beginning of the ascending aorta seen on a parasternal long axis. This is a parasternal. This is a right parasternal, which we talked about, to see the ascending aorta. A very skilled sonographer will probably be able to do this one. Okay, but it's difficult. This is the aortic arch from suprasternal, and this is the descending. So the descending from the subcostal is the same way as IVC, but I find that you go more perpendicular, right? Not just this, more perpendicular. Okay, and it's not usually more than 12 o'clock that you see it. Right, Brian?
Yes,
agree?
no, definitely, for sure, yeah.
This is a flap, dilated aortic root, clearly a dissection, right? This is a flap seen, this is, sorry, double lumen seen in the arch, right? And in the descending aorta. So you can see it in multiple areas.
And that top right view is still a suprasternal view, correct?
Correct.
It's just like it's quite obvious now compared to
correct, with angling toward the right a bit.
Sometimes when you can't get that one, you get it from the supraclavicular on both sides, or just under.
Really, you go supraclavicular? Oh, I've never tried that.
Yeah. Well, okay. I'm sure it has to do so much with just anatomy where the heart actually is, right? Some patients the heart is so displaced towards the diaphragm, you can't really get a peristernal view at all of anything, right?
I'm just going to say, I think we just need to be a bit careful, though. Like, still the sensitivity, like, it's a good rule-in test, but you shouldn't stop. Right?
The
next test. That's the important.
Oh, absolutely. It has not a very good negative predictive value, and we're going to talk about that. So, although this is the European Association of Echo, and they seem to be more into transthoracic echo for dissection than Americans. So they say, although CT-TEE is the technique of choice for aortic dissection diagnosis, transthoracic echo may be used as the initial imaging modality in the emergency setting. So I'll definitely try transthoracic on everybody that I suspect dissection. Now, sensitivity classically is 59 to 83% and specificity of 63 to 93%. So I would say high specificity, a bit lower sensitivity. Not too bad, though. Okay, now for type A dissection is higher, for type B dissection is much lower. So for type B, I wouldn't rely at all. Like, I wouldn't probably be able to catch it.